Welcome to the Radong Smart Review GU Cancer series. So, for decades, treating kidney cancer with radiation was, well, it was considered a fool's errand.
Oh, absolutely.
Right, like we were all taught in medical school that renal cell carcinoma was fundamentally radioresistant.
Just completely immune to it.
Yeah, exactly. You could pump conventional fractionation at it all day, and the tumor would just sit there, shrugging off the dose.
Yeah.
It was a surgical disease, full stop.
Right.
But the introduction of ablative doses through SBRT hasn't just challenged that dogma. It's completely shattered it. I mean, we're seeing local control rates that really rival the scalpel now.
We really are. We're dealing with a massive paradigm shift today. Because, like you said, localized RCC is historically a surgical disease, but ablative dose SBRT has entirely changed the paradigm for medically inoperable patients.
It's wild to see how far it's come.
It really is. So today we're dissecting exactly how and why that shift happened. We'll be pulling heavily from the RSCK retrospective data, the landmark Fast Track 2 prospective trial, and we'll navigate the nuances of the Radster trial.
Oh, the Radster trap. We definitely need to get into that.
Oh, for sure. Our mission today is to give you, the listener, the exact framework you need to walk into an oral board exam or, a multidisciplinary tumor board and defend an SBRT plan for localized kidney cancer with absolute bulletproof confidence.
And you really need this framework because boards heavily test the small renal mass algorithm. You need to know exactly when to pull the trigger on partial nephrectomy, when to watch and wait, and when to irradiate.
Exactly. And oral boards absolutely love the medically inoperable patient scenario.
Oh, they do. They love it. It forces you to demonstrate cross-modality logic. But, beyond the exams in your real-world clinic, urology is going to refer these exact patients to you. And they expect a confident, nuanced plan.
Right. They don't want a generic consultation.
No, they want to know your target constraints, the expected renal decline, the exact rationale backing your dose selection.
Yep. So to keep us anchored today, we're going to follow a specific patient through this entire process. You will definitely see this guy in your clinic within your first month of practice.
Literally day one.
Probably day one, yeah. So he's a 72-year-old man. He has severe COPD, requiring home oxygen, history of hypertension, obesity, and baseline chronic kidney disease.
Okay.
His CKD is currently marked by a creatinine of 1.4 and an eGFR of 48.
Oof. Yeah, that eGFR of 48, that is the ticking clock in this case.
It really is.
We'll definitely be coming back to that number a lot. So let's say he gets some unrelated abdominal imaging for, vague GI complaints.
Right. Typical incidentaloma.
Exactly. And they find this incidental 4.6 centimeter enhancing exophytic solid mass on the midpole of his right kidney. It's completely asymptomatic. No hematuria, no flank pain, no weight loss, no night sweats.
Just sitting there. Just sitting there. So dedicated renal protocol imaging confirms the mass, and it shows no renal vein extension, no paranephric extension into Gerota's fascia, and absolutely no suspicious adenopathy. We also have a negative chest CT. Okay, so a classic incidentaloma, perfectly localized.
Yep. They do a percutaneous core biopsy, which confirms clear cell RCC, ISUP grade 2. So urology evaluates him, and they immediately pump the brakes on surgery.
Which makes sense with the COPD.
Right. His severe COPD and home oxygen requirement make him just a terrible operative candidate from an anesthesia standpoint. And they're highly concerned about pushing him into end-stage renal disease due to the surgical ischemia time for a partial nephrectomy.
Clamping that hilum is risky.
Super risky. So the urologist sends him to us and asks a very direct question. They ask, can radiation cure this?
And that is the million-dollar consult question. But, before we start drawing target volumes or throwing out dose fractionations, we really have to establish the biological foundation of what we're treating here.
Let's start at the very beginning.
Right. So let's assume you already know we're dealing with a tumor of cortical origin. What really matters for modern literature is that it's the clear cell subtype.
Clear cell is everywhere in the data.
It is. Whether you're looking at Fast Track 2, IROSEC, or even the systemic immunotherapy trials, clear cell is the absolute protagonist driving the data. It just makes up the vast majority of cases.
I do see a lot of pathology reports coming back with papillary or chromophobe variants too, though.
Yeah.
Does that change our SBRT approach at this localized stage?
From an SBRT dosing perspective, no. We treat them exactly the same. However, from a prognostic standpoint, papillary and chromophobe variants generally behave a bit more indolently in the localized setting compared to clear cell.
Okay, good to know.
But the real curveball you have to watch for in your localized masses is the oncocytoma.
Oh, right, the benign masquerader.
Exactly. It's a benign entity that is virtually indistinguishable from malignant RCC on standard imaging. It's the primary reason why tiny incidental masses, especially those under 2 centimeters, have such a high rate of being benign on final surgical pathology.
Which totally justifies why active surveillance is heavily utilized for those very small masses.
Right. It provides the biological cover for it.
That makes a lot of sense.
Yeah.
We definitely don't want to irradiate a benign oncocytoma if we don't have to. So, diving into our 72-year-old's clinic visit, I usually start my workup by ensuring we have a strict triphasic renal protocol CT.
Essential.
But I've seen urology send these over with just a single venous phase scan. It drives me crazy.
What's your absolute baseline requirement before you even think about treating?
Oh, you're completely justified in wanting that dedicated triphasic scan. A standard single-phase CT just isn't enough, because you really need to evaluate the enhancement pattern of the mass during the corticomedullary, the nephrographic, and the excretory phases.
That's how we tell it apart from a cyst, right? Exactly. That's how we differentiate a true solid tumor from a hyperdense cyst. Beyond the imaging, you obviously need a thorough H&P. You must have a CBC to check for perineoplastic syndromes.
Right. RCC is famous for causing polycythemia.
Because of the ectopic erythropoietin production, yeah. Or sometimes it causes anemia. And you need a comprehensive metabolic panel heavily focusing on the renal function. That baseline eGFR of 48 is our absolute anchor point for predicting toxicity.
Yeah, I'm always fending off questions from patients asking if they need like a P scan or a brain MRI to make sure it hasn't spread. I have to explain that we don't just shotgun whole body imaging for a localized T1 mass unless there's a clinical trigger.
And you're following the guidelines perfectly there. In localized asymptomatic RCC, bone scans and brain imaging are strictly symptom-driven.
So no routine bone scans.
Right. If he comes in complaining of new localized bone pain or his alk phos is through the roof, then yes, obviously get the bone scan. If he has focal neurologic deficits, get the MRI. But they are absolutely not part of the routine staging workup.
Makes sense.
I will add one major anatomical caveat, though. If the imaging shows a central mass sitting in the renal pelvis, rather than an exophytic cortical mass like our patient has,
Oh, you have to rule out upper tract urothelial.
you are obligated to rule out upper tract urothelial carcinoma. That is a completely different disease process requiring urine cytology, ureteroscopy, and an entirely different treatment paradigm.
That's a great distinction. Looking at the biopsy, in our case, we have a percutaneous core biopsy. I occasionally see community referrals where they only did a fine needle aspiration and FNA. Why is that problematic?
It's highly problematic because an FNA just yields a slurry of cells. It completely destroys the architectural context.
So the pathologist is just guessing.
Basically, to reliably diagnose RCC, differentiate the subtype, and accurately assign the ISUP nucleolar grade, the pathologist really needs solid tissue cores. A negative FNA in a suspicious solid renal mass means absolutely nothing. Always push for the core biopsy.
Got it. All right, let's talk staging, because the size of our patient's tumor sets up a massive oral board trap. Our patient has a 4.6 centimeter mass. Intuitively, 4.6 centimeters feels a bit large.
It sounds big, sure.
Right, it's crossed that 4 centimeter threshold.
Yeah.
I've seen residents reflexively bump this up to a T2 simply because it's larger than the T1A cutoff. Does crossing the 4 centimeter mark automatically bump this to a T2?
And that is board trap number 2. And falling for it is a guaranteed way to derail your entire case presentation. Staging a 4.6 centimeter organ-confined mass as a T2A is just fundamentally incorrect.
Okay, so what is it?
The clinical stage here is strictly CT1B N0M0.
Let's explicitly define those cutoffs, because understanding the biological behavior behind them helps cement them in memory.
Sure, the staging ladder for localized RCC is heavily driven by size. Historical surgical databases showed clear inflection points in metastatic risk and local recurrence based on these very specific measurements. So a T1A tumor is strictly 4 centimeters or less. Once you cross that line, meaning greater than 4 centimeters up to 7 centimeters, you are in T1B territory.
So our patient's 4.6 centimeter mass sits right at the lower end of T1B.
Exactly. You do not hit T2A until the tumor is strictly greater than 7 centimeters, up to 10 centimeters. T2B is anything larger than 10 centimeters.
And it only becomes a T3 when it invades the vasculature.
Right. It only jumps to T3 when it starts invading the major vasculature, like the renal vein or the perinephric fat, but strictly remains contained within Gerota's fascia.
That is a critical baseline because the T1A versus T1B distinction really dictates the entire flow of the treatment algorithm. Now that we have his staging locked in as a T1B and surgery is completely off the table due to his severe COPD, we have to look at the non-surgical options.
Right.
But before we get there, we always have to acknowledge the gold standard we are deviating from.
We do. I mean, if this 72-year-old had the lungs of a marathon runner and perfect kidneys, the absolute gold standard recommendation would be a partial nephrectomy.
Right. We prioritize the partial nephrectomy, specifically to preserve nephrons. Sparing that functional renal parenchyma is crucial to prevent the downstream cardiovascular and metabolic disasters that come with end-stage renal disease.
Absolutely.
The landmark trial you need to know here is EORTC 30904. But here is the nuance. I often hear people incorrectly state that EORTC 30904 proved an overall survival advantage for partial nephrectomy over radical nephrectomy. But it actually didn't, right?
That's a very common misconception. EORTC 30904 was actually a non-inferiority trial that surprisingly showed a slight overall survival advantage for the radical nephrectomy arm in the intent to treat analysis.
Which caused massive controversy.
Oh, huge controversy. But the key takeaway, and how the urology community interpreted the long-term data, was that partial nephrectomy provided equivalent oncologic control while significantly reducing the incidence of severe chronic kidney disease.
Okay, so it proved that functionally sparing the kidney is superior, even if it didn't give us a clean overall survival win.
Precisely. But since our guy's hilum isn't getting clamped anytime soon, we pivot.
Right, the scalpels is out. So when I'm talking to residents about navigating localized RCC without surgery, I use a simple mnemonic, SAS, SAS. It stands for Surveillance, Ablation, SBRT.
I like that.
It keeps you structured when evaluating the medically inoperable patient.
SAS is a great framework. Let's apply that if-then logic to our patient. So the first S is active surveillance.
Right.
If we were dealing with an 85-year-old with a 1.5 centimeter heavily cystic or indeterminate CT1A lesion, surveillance would be brilliant. The competing risks of mortality would far outweigh the risk of the tiny tumor spreading.
But why do we immediately reject surveillance for our 72-year-old?
Because it's a 4.6 centimeter biopsy-proven clear cell carcinoma. The growth kinetics of a nearly 5 centimeter clear cell tumor are entirely different from a 1.5 centimeter incidentaloma.
Yeah, at 4.6 centimeters, it has already established an aggressive vascular supply. And while his COPD is severe, he's 72. He still has a meaningful life expectancy. We can't just watch a documented, moderately sized cancer grow until it throws a lung metastasis. Intervention is mandatory.
I agree completely. Active surveillance is inappropriate here. That brings us to the A in SAS. Thermal ablation, specifically radiofrequency ablation or cryoablation.
Right.
Interventional radiology does a fantastic job with these, but tumor size is their absolute Achilles heel.
This is where I use the campfire analogy with patients.
Whoa, let's hear it.
Trying to treat a 4.6 centimeter tumor with thermal ablation is like trying to heat a massive circus tent with a single tiny campfire in the middle. It gets incredibly hot right in the dead center, but out at the edges, at the tumor periphery, where it interfaces with normal kidney, they just don't get the sustained uniform heat required for reliable cell death. The physical properties of thermal diffusion break down as the volume increases.
The campfire analogy is excellent, and, there's a physiological mechanism making it even worse, the heat sink effect.
Oh, right, the blood flow.
Exactly. The kidney is one of the most highly perfused organs in the body. It processes massive volumes of blood every single minute. When an interventional radiologist tries to ablate a large tumor, the prominent blood vessels coursing near the periphery of the mass act exactly like a car radiator.
Wow, so it actually cools the tissue.
Yes. As the tissue heats up, the flowing blood physically carries the heat away from the treatment zone. It cools the edges of the tumor, leaving viable, sublethally injured cancer cells behind.
That's a huge problem.
It is. Ablation is a stellar option for T1A tumors strictly under 3 centimeters. But once you cross into that 4 centimeter T1B territory, the local failure rates with ablation start to climb unacceptably high.
Which perfectly tees up the final S in SAS SBRT. By a strict process of elimination, SBRT emerges as the definitive prime recommendation for this patient. The beauty of SBRT is that photons do not care about the heat sink effect.
They really don't.
A linear accelerator deposits energy based on tissue density and the treatment plan, completely independent of how fast the blood is flowing. We can deliver a uniform ablative dose across the entire 4.6 centimeter volume without worrying about vascular cooling at the periphery.
Precisely. The physics of radiation bypass the physiological limitations of thermal ablation. SBRT is the clear answer here.
But Arriving at SBRT logically is one thing. If you're presenting this in a multidisciplinary tumor board, the urologists are going to demand hard evidence. We need to anchor this decision in the data. Let's start with the foundational retrospective work that really put this on the map.
You absolutely need to know the IRCK data. IRCK stands for the International Radiosurgery Oncology Consortium for Kidney. This was a massive, pooled, multi-center analysis that really provided the retrospective confidence we needed as a field.
What did they find?
Well, it proved that long-term local control with SBRT is phenomenal, upwards of 97% in some subsets. It established that cancer-specific survival is excellent, and critically, it gave us the first large-scale look at toxicity.
And the toxicity was acceptable.
Yes. IRIS-6 showed that while a modest decline in renal function is expected, the actual rate of progression to end-stage renal disease requiring dialysis is remarkably uncommon.
Okay, so the IRCK data is great for giving us a wide-angle historical view. But retrospective data always has selection bias. We need the prospective gold standard. We need the trial that dictates our specific prescription, and that is Fast Track 2.
Yes, the big one.
If you are treating RCC, you need to know this trial inside and out.
Fast Track 2 is the defining trial for modern renal SBRT. It was a non-randomized, multi-center phase 2 study run by the Trans-Tasman Radiation Oncology Group, or TRIOG, looking specifically at primary kidney cancer.
The patient population is what makes it so relevant to our guy, right?
Exactly. They enrolled patients who are medically inoperable, technically at high risk for surgery, or who outright declined surgery. That matches our 72-year-old perfectly. And the median tumor size in the Fast Track 2 cohort was exactly 4.6 centimeters.
Wait, really? That's crazy. An exact match for our case anchor.
Literally an exact match.
So how did the investigators design the dose regimens? Because getting the dose right in a highly radioresistant histology is everything.
They utilize a very strict size-based dosing stratification, which comes down to balancing the biological effective dose, the BED, with the volume of normal kidney being irradiated.
Okay, what were the tiers?
For tumors 4 centimeters or smaller, meaning the T1A group, they prescribed 26 grays in a single fraction. For tumors greater than 4 centimeters up to 10 centimeters, the T1B and T2A groups, they prescribed 42 gray in 3 fractions.
I would like to point out the radiobiology here. RCC has a notoriously low alpha-beta ratio, meaning it is exquisitely sensitive to fraction size.
Right.
Giving 2 grays a day for 7 weeks just allowed the tumor to repair itself. But when you deliver 14 grays per fraction or a massive 26 grays single shot, you trigger endothelial apoptosis. You destroy the tumor's microvasculature. It's a completely different mechanism of cell death.
It changes everything.
So for our patient with a 4.6 centimeter mass, the prescription is unequivocally 42 gray in 3 fractions.
Unquestionably. And the outcomes from Fast Track 2 validate that regimen beautifully. They had 0 local failures.
Wow.
Let that sink in. 0 local failures at the median follow-up. Distant failure-free survival was also outstanding.
Did the overall survival take a hit, though?
No, the overall survival rate did dip over time, but that perfectly reflects the reality of treating a highly comorbid population. These patients were succumbing to their severe COPD, heart failure, and ischemic heart disease, not to local kidney cancer progression.
Right, they were dying of other causes. What about safety?
In terms of safety, there was roughly a 10% rate of grade 3 toxicity, mostly transient things, but absolutely 0 grade 4 or grade 5 treatment-related events. It's a stellar safety and efficacy profile.
Okay, the Fast Track 2 data is robust, but I want to throw a wrench in the gears.
Sure.
Let's say you're presenting this 42 gray plan, and a sharp interventional radiologist sneaks up and brings up the RADSTER trial.
RADSTER.
RADSTER was a randomized trial directly comparing SBRT to radiofrequency ablation for small renal masses. If I recall, the protocol required post-treatment biopsies, and those per-protocol biopsies favored RFA. Doesn't that mean ablation is better? Doesn't that prove ablation is oncologically superior to SBRT?
That is a brilliant point to bring up because it highlights one of the most dangerous conceptual traps in radiation oncology. RADSTER proved that both modalities are highly feasible, but it absolutely did not prove that RFA is superior.
But the biopsies favored RFA.
You are correct that the post-treatment biopsies favored RFA, but using a biopsy to measure SBRT success is a fundamental misunderstanding of the radiobiology. A post-SBRT biopsy is a terrible, incredibly misleading surrogate for clinical failure.
Break down the cellular mechanism there. Why is it misleading?
It comes down to how these different modalities kill cells. When you use thermal ablation, you are rapidly boiling the tissue. You cause immediate coagulative necrosis. The cell membranes burst, proteins denature, and the cells are demonstrably dead the second the probe is turned off.
Right, it's instant.
But SBRT is more insidious. We are catastrophically shredding the DNA and destroying the microvasculature. Many of these cancer cells don't immediately undergo apoptosis. Instead, they are driven into a state of permanent senescence.
Senescence, meaning they just stop replicating.
Exactly. They might sit there, structurally intact, looking perfectly viable to a pathologist looking through a microscope 6, 9, or even 12 months after treatment. But they are reproductively dead. They cannot complete mitosis. They cannot metastasize.
So they're just zombies.
Exactly. So if you stick a needle in that tumor post-SBRT, the pathology report will scream viable tumor, but clinically, the cancer is completely inert.
Right, we see the exact same phenomenon when interpreting post-SBRT biopsies in prostate cancer or lung cancer. The cells are effectively zombies. They're technically alive, but entirely harmless. So the core takeaway from Radster isn't that SBRT fails, it's that SBRT is safe. But using a biopsy as your endpoint for radiation is a flawed methodology.
Completely flawed.
We shouldn't be routinely biopsying these patients after treatment just to prove it worked.
Exactly. We monitor success functionally and radiographically. We follow them with imaging, not needles.
Okay, we've successfully defended our recommendation. We were locked in for 42 grays and 3 fractions. Now we have to move from the theory to the console. Let's get into the technical workshop and outline the target logic. How are you setting this patient up in simulation? Because hitting a moving 4.6 centimeter target next to the bowel requires extreme precision.
Simulation demands meticulous attention. You're delivering ablative doses where millimeters matter. The patient must be positioned supine with highly stable, rigid immobilization. A custom vacuum cushion is standard. We need the patient comfortable enough that they don't shift during the delivery.
What about contrast?
Ideally, intravenous contrast is incredibly helpful during simulation to sharply delineate the enhancing tumor from the normal renal parenchyma.
Okay, wait, our patient has an EGFR of 48. Radiology is going to push back hard on full-dose IV contrast.
And they should. At an EGFR of 48, many institutions will outright refuse standard IV contrast due to the risk of contrast-induced nephropathy. We cannot risk further injuring his baseline kidney function just for a better simulation scan.
So what do we do?
In these cases, you often have to rely on a non-contrast simulation CT and use rigid or deformable image registration to fuse a diagnostic pretreatment MRI or CT onto your planning scan. You rely on the fusion to define your target.
Got it. The other elephant in the room is motion. Kidneys are essentially attached to the diaphragm. They move dramatically with every single breath.
Oh yeah, mandatory respiratory motion assessment is absolutely non-negotiable. You must perform a 4D CT or utilize an equivalent motion management workflow. You have to capture the full superior-inferior excursion of that kidney during the breathing cycle.
Can we use breath hold?
Some centers might use abdominal compression to limit the motion, or if the patient can tolerate it, deep inspiration breath hold. But given our patient's severe COPD, breath hold is likely impossible. We have to map the free breathing motion.
Okay, let's talk about contouring the volumes. We find the enhancing mass on our fused imaging. What about the regional lymph nodes? Do we include a prophylactic nodal basin in our target?
Emphatically no. There is zero role for elective nodal basin irradiation in primary RCC SBRT. This is a purely focal, localized, ablative strategy. RCC typically spreads hematogenously, not just lymphatically. Irradiating massive periaortic nodal fields to ablative doses would cause catastrophic gastrointestinal toxicity with absolutely no proven oncologic benefit.
Those are just a tumor.
Your gross tumor volume, the GTV, is strictly the visible enhancing mass, nothing more.
So GTV is the mass itself. Then we use the data from our 4D CT to expand that GTV into an internal target volume, or ITV, which encompasses every position the tumor takes during the respiratory cycle.
Correct. The ITV handles the motion uncertainty. From there, your planning target volume, the PTV, requires very small expansions, typically 3 to 5 millimeters.
At least we image them every day.
Right. We keep margins tight because we rely heavily on daily volumetric image guidance. You must perform a daily cone beam CT on the treatment machine before every single fraction to ensure sub-millimeter alignment. We typically deliver this using highly conformal techniques like VMAT or robotic radiosurgery to sculpt the high dose tightly around the tumor.
I want to focus on the specific anatomy in our case, because the spatial relationship dictates the risk. We have a right mid-pole kidney tumor. We obviously know we need to minimize the dose to the uninvolved ipsilateral healthy renal cortex to preserve his EGFR. But what is the terrifying dose-limiting structure lurking right next to the right kidney?
For any right-sided tumor, particularly those in the mid to upper pole, the duodenum is the absolute danger zone. It is the critical organ at risk that will make or break your plan. The D2 segment of the duodenum wraps around the head of the pancreas and often sits flush against the anterior medial surface of the right kidney.
And the bowel does not handle 14 grays per fraction well. What happens if we don't respect the duodenal constraints?
It's bad. If you get sloppy with your contouring or fail to verify your daily cone beam CT and you spill ablative doses into that duodenal wall, you will cause devastating, irreversible gastrointestinal toxicity.
Like what?
I'm talking about severe, full-thickness perforation, fistula formation, and intractable ulceration. If you recall the IROCK retrospective data, their major cautionary tale was a patient who developed an acute grade 4 duodenal ulcer, which subsequently progressed to grade 4 gastritis.
Oh, wow.
It's a rare complication, but it is catastrophic when it happens. You must prioritize duodenal sparing, prioritizing the bowel constraints, even if it means slightly compromising your PTV coverage right at the interface.
Okay, so the plan is tight, the duodenum is spared, and the logic is sound. Now we have to sit down in the exam room and actually talk to the 72-year-old patient. We have to distill all this complex radiobiology, trial data, and technical physics into a clear, compassionate conversation.
Right.
But before we do the patient role play, how would you present this formally? Like, give me the 60-second board script for this exact case.
Okay, here is exactly how you deliver it to an attending or an examiner. This is a 72-year-old man with a biopsy-proven clear cell RCC, clinical stage T1B and 0M0. He is deemed medically inoperable due to severe cardiopulmonary comorbidities and baseline CKD.
I'll start.
Workup is complete, including renal protocol, cross-sectional imaging, chest staging, and core biopsy. Standard non-surgical options in this setting include active surveillance, thermal ablation, and SBRT.
You set up the SAS mnemonic.
Exactly. Because this is a 4.6 centimeter biopsy-proven clear cell lesion, active surveillance is inappropriate. Thermal ablation is also less favorable because local control efficacy declines significantly as tumor size increases beyond 3 to 4 centimeters due to the heat sink effect.
Perfect elimination.
Therefore, I recommend primary SBRT utilizing the Fast Track 2 regimen of 42 grays and 3 fractions. I would provide explicit patient counseling regarding expected renal function decline and the low but real risk of dialysis given his tenuous baseline CKD, and I would emphasize that follow-up will be strictly imaging-based rather than utilizing routine post-treatment biopsies.
That is exactly what an examiner wants to hear. Diagnosis, staging, ruling out alternatives with solid rationale, stating the exact dose, and preempting the toxicity management.
It hits every required mark.
Let's shift gears to the patient interaction. I'll play the patient. I'm 72, I'm tethered to an oxygen tank, and I know my kidneys are already failing. You're telling me you want to shoot high-dose radiation at my one good kidney. How do you explain the renal risk to me, given my starting EGFR is 48?
I would look him straight in the eye and say, Mr. Smith, this targeted radiation is highly effective at destroying the tumor. But the reality of physics is that it is impossible to avoid irradiating a small rim of the healthy, functioning kidney tissue immediately surrounding the mass. Because of that collateral damage, your overall kidney function will decline after we treat you.
That's honest.
And this is where you use the clinical anchor, the 10 to 15 rule. You must explicitly counsel the patient to expect a 10 to 15 milliliter per minute decline in their EGFR over the first 1 to 2 years following SBRT.
I see the logic there, but practically speaking, if I'm starting at an EGFR of 48, a 15-point drop puts me at 33. That's knocking on the door of stage 4 CKD. How do we manage that reality?
It's a stark reality, and we manage it through aggressive preventative care. I would tell him, while the absolute risk of needing dialysis after this treatment is low for the general population because your starting number is 48, dropping another 15 points puts you in a highly vulnerable zone.
So what's the plan?
To protect your remaining kidney function and keep you off a dialysis machine, it is absolutely critical that we work closely with your primary care doctor and your nephrologist. We need to tightly control your blood pressure to prevent hypertensive damage to the surviving nephrons. Furthermore, you must strictly avoid any nephrotoxic drugs.
Oh, like Advil.
Exactly. That means absolutely no daily ibuprofen or NSAIDs, and we have to be very careful with certain antibiotics or future 4V contrast for the rest of your life.
That sets a very honest, serious tone. It empowers the patient to protect their own outcomes. What about when he comes back to see us for his 6-month follow-up?
That requires setting expectations early, tying back to the senescence concept we discussed with Radster. Mr. Smith, when you come back for your checkups, we are going to rely on CT or MRI scans to prove the tumor is dying. Here's the cat's cucking. The tumor will likely still be visible on the scan.
It doesn't disappear.
It won't vanish, but it will lose its blood supply, stop enhancing, and stop growing. We will not be poking it with a biopsy needle to check if it's dead because the radiation causes cellular changes that make biopsies incredibly misleading. We trust the imaging.
That preemptive counseling is vital because what always happens is the patient's primary care doctor orders a scan for something else 6 months later, reads the report that says stable 4.6 centimeter mass, and panics. They tell the patient the treatment failed.
Oh, it happens all the time.
By educating the patient up front that a non-enhancing scar is exactly our definition of success, you save them months of anxiety.
Precisely. In radiation oncology, proactive education is the best toxicity management.
We've built an incredibly solid foundation today. To really lock these concepts in for anyone preparing for boards or clinic, let's transition to a quick board-style rapid review. We'll summarize the major traps and then hit a few rapid-fire clinical scenarios.
Let's do it. Reviewing the traps is critical. Trap number 1, never recommend adjuvant radiation therapy to the renal bed after a nephrectomy for RCC, even if the surgeon leaves a focally positive margin, or if there is node-positive disease.
Please don't do it.
Historically, trials looking at postoperative radiation showed significant gastrointestinal toxicity with absolutely zero survival benefit. The modern adjuvant conversation for high-risk clear cell RCC belongs entirely to medical oncology and adjuvant pembrolizumab.
Good. Trap number 2.
Trap number 2. Do not misstage a 4.6 centimeter mass. It is a T1B, not a T2A. The cutoff is 7 centimeters. And trap number 3. Do not speak in absolutes on an oral board. Do not say SBRT is the universal standard of care for all inoperable patients. The correct, defensible language is that SBRT is a strong, definitive option for selected medically inoperable patients.
Perfect. Let's dive into the board blitz. Question 1. You have a 68-year-old man. He has a solitary functioning kidney after donating the other one years ago. His baseline eGFR is 35. He presents with a 3.8 centimeter biopsy-proven clear cell RCC. Cardiology formally deems him medically inoperable due to severe ischemic heart disease and recent stents. What is the move?
The move is SBRT, specifically prescribing 26 gray in a single fraction. Let's break down the logic. A radical nephrectomy is out because taking his solitary kidney guarantees immediate, lifelong, irreversible dialysis.
Yeah.
A partial nephrectomy would normally be the ideal nephron-sparing choice, but cardiology took surgery off the table. Active surveillance is poor practice for a 3.8 centimeter biopsy-proven clear cell tumor in a 68-year-old. It's going to grow.
Definitely.
Ablation is out because it's pushing that 4 centimeter boundary where the heat sink effect causes failures. SBRT is the best definitive option. Because the tumor is exactly under the 4 centimeter threshold, we use the Fast Track 2 T1A anchor of 26 grays in a single fraction.
Excellent breakdown. Question 2. A 62-year-old woman just underwent a radical nephrectomy for what turned out to be a PT3A-N1 clear cell RCC. The operative note describes a difficult dissection, and the final pathology report notes a focally positive surgical margin at the vascular hilum. Urology refers her to you, asking if you want to offer adjuvant radiation to the renal bed to sterilize the margin. What is your answer?
The answer is a polite but firm no. As we just covered in the traps, there is no routine role for adjuvant radiation therapy in this setting. The risk of small bowel toxicity far outweighs any theoretical local control benefit, and it does not improve survival. The standard of care is to ensure she is healed from surgery and immediately send her to medical oncology for a thorough discussion regarding adjuvant immunotherapy, specifically pembrolizumab based on the Keynote 564 data.
Spot on. Final question, question 3. You are planning SBRT for a 5 centimeter right upper pole RCC. The tumor is largely exophytic and sits flush against the adjacent bowel. Which specific organ at risk is going to be your primary dose-limiting constraint during planning?
That is the duodenum. Because it is a right-sided upper pore mass, the duodenum is the critical structure in the crosshairs. You have to use rigorous motion assessment, highly precise contouring, and strict adherence to fractionation-specific duodenal dose constraints. You must protect the duodenum at all costs to prevent catastrophic ulceration or perforation, even if it requires slightly underdosing the very edge of the PTV.
Amazing. We have covered an immense amount of ground today. We took a complex 72-year-old patient with a T1B clear cell mass, systematically ruled out surgery due to his comorbidities, logically skipped thermal ablation because of the tumor size and the physical limitations of the heat sink effect, and confidently arrives at a curative plan of 42 grays in 3 fractions based on the Fast Track 2 data.
A perfect plan.
And we did it while carefully counseling him on the expected 10 to 15-point drop in his eGFR and managing the long-term imaging expectations based on the biology of senescence.
It's a perfect illustration of how far radiation oncology has evolved. We've taken a disease that was considered completely radioresistant for decades, and by deeply understanding the biology of ablative dosing, we've created a highly effective, non-invasive cure for patients who previously had no good options. But, I want to leave you with a look forward, because the field is already moving past the localized stage.
Ooh, where do you see the next big paradigm shift happening?
We've mastered the primary localized kidney lesion today, but the real Wild West is how SBRT interacts with modern immunotherapy in the oligometastatic setting.
The abscopal effect.
Exactly. Does delivering an ablative dose to the primary kidney tumor release a cascade of neoantigens that primes the immune system? Does it synergize with systemic checkpoint inhibitors to attack distant metastases?
Yeah.
Can we reliably induce an abscopal effect? That intersection of local, precise physical ablation and massive systemic immune activation is exactly where the field of GU oncology is heading next.
That is an incredibly provocative thought to end on. The idea that physically destroying the kidney primary could train the immune system to clear microscopic disease elsewhere is fascinating, and it's definitely going to drive the next decade of trials. Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.